So we will continue with our discussion about the insulin therapy in diabetes. Last time we were discussing about the insulin regimen, so I'll continue with the same. I'll draw some representative insulin regimens. Most important is basal bolus regimen. So in basal bolus regimen, we give one long acting insulin at bedtime usually, which provides basal insulin coverage for nearly 24 hours, and we give 3 shots of rapid acting insulin analogs with each of the meal, which provide parendial insulin coverage. So here if I draw this insulin effect, and x-axis shows timing of meal. So morning, lunch, dinner and bedtime. So long acting insulin, which is usually given at bedtime, it provides the basal insulin coverage for almost 24 hours. And rapid acting insulin analogs, which are given with each of the meal, they cover for the parendial glucose exertion. So they correspond to the physiological peak of insulin after each meal. So this is about the basal bolus regimen. It is a very good regimen for both type 1 diabetes as well as type 2 diabetes patients. Now we'll talk about the another important regimen, that is mixed start regimen. So in mixed start regimen, usually we give pre-mixed insulins. They are either combination of NPH with regular insulin or rapid acting insulin analog plus protaminated form. So if I draw so 2 injections are given, one before morning, one before breakfast and another before dinner. So this is the NPH, which provides the basal insulin coverage, and this is the regular insulin, which covers for the parendial glucose exertion. So the regular insulin, which is given before breakfast, its effect lasts till the lunch, and one which is given before dinner, its effect lasts till the bedtime. But what if we give the patient rapid acting insulin analogs? Their effect does not last longer. So sometimes we need to give another shot of parendial insulin at lunch. Okay, this is about mixed start regimen. It is convenient because you have to give only 2 injections. In basal bolus, you have to give 4 injections a day. Here you have to give only 2 injections, but it is not an optimal regimen for type 1 diabetes patient because it enforces a rigid schedule on timing of meals, on content of meals, on physical activity. But basal bolus regimen, it provides type 1 diabetes patient with the flexibility in terms of physical activity or timing of meals. Now there is another regimen which can be given in patient of type 1 diabetes particularly, that is continuous subcutaneous insulin infusion. So we have usually we have insulin pumps for that. They provide the basal insulin coverage, and we have to give bolus with each meal. So bolus is patient instructed. So I want to show you something here. So look, This basal coverage, this basal rate of infusion can be altered. So multiple basal infusion rates can be programmed. This is one of its advantage, because usually in night the requirement for insulin is lower than in daytime. So there, if you lower the basal infusion rate in the night, so there is decreased risk of nocturnal hypoglycemia. Similarly, the basal infusion rate that is increased slightly prior to awakening of the patient to cover for Dawn's phenomenon. I'll tell you what is Dawn's phenomenon. Early morning at 6 a.m., 7 a.m., there is increase of counter-regulatory hormones like cortisol, like growth hormone. They increase the glucose level in the morning. So there is increased insulin demand in the morning to cover for that reflexive increase in glucose levels. So that at that time we can increase the basal infusion rate. So this is one of the advantage of continuous subcutaneous insulin infusion, that you can set multiple rates of basal infusion. Apart from that, the basal infusion rate, it can be altered at times of physical activity. And parenteral boluses, they are patient instructed. Okay, the bolus injection dose, they are patient instructed. So this is again very important, very good regimen for type 1 diabetes patients. So as far as the ADA recommendations say, they say that type 1 diabetes patients should have either basal bolus regimen or continuous subcutaneous insulin infusion. Now let me tell you about few of the terms here which I have mentioned already. One is Dawn's phenomenon and another is Somogyi effect. This Dawn's phenomenon, it is physiological. It is physiological rise in blood glucose in early morning due to increase of counter-regulatory hormones. Cortisol or growth hormone. So in early morning there is surge of growth hormone and cortisol, so they increase the blood glucose level. It is physiological. But another is Somogyi effect. It is pathological. It is pathological. In this there is reflexive increase in early morning blood glucose levels in response to nocturnal hypoglycemia. So nocturnal hypoglycemia results in reflexive increase in early morning blood glucose. So this is pathological. Now the treatment is also different, so that's why it becomes important. For Dawn phenomenon, if you want to cover for it, although it is physiological, you have to increase 1-2 units of basal insulin, which you give at bedtime. But for Somogyi effect, already there is nocturnal hypoglycemia, so you have to decrease the dose by 1-2 units, so that nocturnal hypoglycemia will not occur and that will not result in reflexive increase in blood glucose levels in early morning. So this is all about the insulin regimens. Now we'll move on to our main topic, that is insulin therapy in type 1 diabetes and type 2. So let's discuss the insulin therapy in type 1 diabetes. Because you all know that type 1 diabetes is an insulopenic state. There is absolute insulin deficiency. So insulin is essential in the treatment of type 1 diabetes. No other oral anti-diabetic drug, or for that matter also injectable drug, is effective in treatment of type 1 diabetes except amylin analogs. So I want to tell you a word about the amylin analogs. Amylin, it is basically a peptide which is co-secreted by beta islet cells. Their function is exactly not known, but it is said that amylin analogs, they decrease the parenteral blood glucose. So they are also approved for the treatment of parenteral hyperglycemia in type 1 diabetes and type 2 diabetes patients who are already on insulin. So this is the only drug which is effective in type 1 diabetes apart from insulin. But we will focus right now on the insulin therapy in type 1 diabetes. So insulin is essential for the management of type 1 diabetes, and it is recommended that either you give basal bolus regimen to the patient or you give continuous subcutaneous insulin infusion. Mixed start regimen is not optimal because it enforces a rigid schedule on patients of type 1 diabetes in terms of timing of meals, content of meals, physical activity. Now, let me tell you that how will you start? Usually, the dose which is required, the initial dose in type 1 diabetes patient is 0.4 to 1 units per kg per day. So, usual initial dose is zero point 0.5 units per kg per day. The range is 0.4 to 1, but usual dose in a metabolically stable patient is 0.5 units per kg per day. Supposedly there is a patient of 60 kg. That means so you will how much dose you will start with? You will start 30 units. Okay. Now this 30 units, 50% is given as basal insulin. 50% is given as basal insulin, and rest of the 50% is given as parenteral insulin. So to put it simple, you can give supposedly the patient is of 60 kg, so you give him 30 units total. Now 15 units as basal insulin at bedtime, and rest of the 15 units you distribute it to breakfast, lunch and dinner as parenteral insulin. So 5 5 5 with each of the meal. This is one way. But what is recommended is that you should train type 1 diabetes patients to adjust their parenteral doses with respect to the anticipated carbohydrate intake or physical activity or pre-parenteral blood glucose levels. Okay, so supposedly what I want to say that key one way is that you tell the patient, you fix the dose. You give him 15 units at bedtime and tell him to take 5 units with each of the meal. But it will not be as much effective as that would be if a patient is adjusting the parenteral doses according to the anticipated carbohydrate intake or pre-parenteral glucose level. So how will he calculate this dose? So to calculate this dose, as I have told you that parenteral dose, it will depend on two things. It will depend on anticipated carbohydrate intake, and it will also depend on the pre-parenteral blood glucose levels. So if your patient is smart enough, so you have to tell him that he has to take 1 unit for every 10 to 15 grams of carbohydrate. Or I know it is very difficult to actually estimate it. And pre-parenteral glucose, which is also known as correcting insulin. I have told you the glycemic targets. The pre-parenteral glycemic target is 80 to 130 milligram per deciliter. So if patient is having more than 130, so you have to give 1 unit for every 50 milligram per deciliter over pre-parenteral glucose target. Supposingly if a patient is having pre-parenteral glucose levels 150, so it is more than 130, so you have to add 1 unit extra. Okay, supposedly that patient is having 200, I mean to say 130 is your upper limit of normal, right? If a patient, I have told you for every 50 units, okay, for every 50 units you have to add 1 unit. So if a patient is having say 150, so you add 1 unit. If a patient is having 200, so you add 2 units. Likewise. So this is one formula. Another formula is bit tedious, in which you do like this, that body weight into what is patient's blood glucose right now. Supposedly it is 200 minus what is desired. So desired is say 130. Okay. So desired blood glucose, although it is upper limit, you can keep it lower also, divided by 1500. This is another formula. It is bit tedious, so the better one is this one. So this is how a patient can adjust their parenteral doses. It is the optimal thing to do. But otherwise, to make it simple, start with this dose Okay, then 50% give it as basal insulin, 50% as parenteral insulin, and then titrate according to the requirements. Supposingly, if a patient, if you are giving 15 units at bedtime and still patient is having parenteral glucose above the target, say he's having 180, so keep increasing 1-2 units every 3 days. Okay, similarly target for the parenteral insulin, that you are giving 5 units say with the breakfast, still he is having a post parenteral glucose levels more than target, say more than 180, so keep increasing the doses. So this is how you have to titrate. It's a bit tedious task. So this is about the insulin therapy in type 1 diabetes. Now okay, this is about the basal bolus regimen. Next about continuous subcutaneous insulin infusion. So in accordance to what your physician advise you, they will only adjust the basal dose. But parenteral for the, as far as the bolus doses are concerned, there is a inbuilt software in that which will help you in calculating the dose depending upon the anticipated carbohydrate intake or pre-parenteral glucose level. So there is not much of a difficulty in this unless you have a trained physician, and also the patient should also be motivated and he should be trained to do the same. Now, a word about the mixed start regimen. I told you that this is not an optimal regimen for type 1 diabetes, but it can be given in patients um, of type 2 diabetes. So, in mixed start regimen, what you do basically, uh, again, the starting dose will be same. I have told you 0.5 units per kg per day. So, say in a 60 kg patient, the dose would be how much? 30 units. So, 2/3 of the dose you have to give in the morning, and 1/3 in the evening. 2/3 before breakfast and 1/3 before dinner. So 2/3 means 20 units you will give in the uh, before breakfast, and this 10 units you will give before dinner. So this is how you have to give it. Okay, now we'll talk about the treatment insulin therapy in type 2 diabetes. So in type 2 diabetes, when we talk about the insulin therapy, so first of all you need to know about what are the indications. So in treatment naive patient, when first time patient presents to you, when can you think of starting insulin therapy if a patient is lean or if there is an evidence of ongoing catabolism like weight loss, hypertriglyceridemia, ketosis. Important is weight loss. If a patient is having severe weight loss, you can start insulin first time itself. Or if the patient is having symptomatic hyperglycemia, that means polyuria or polydipsia. If a patient is having underlying hepatic or renal disease, because in that case the use of OADs, that becomes a bit cumbersome task. You have to be very cautious about the contraindications. Or if a patient is hospitalized, say patient is having MI, severe sepsis, or for that matter if patient is hospitalized for any reason or patient is acutely ill. Also, if type 1 diabetes is a possibility, that you are not sure that it is a type 1 or type 2, and if a patient is having HbA1c of more than 10% or blood glucose levels more than or equal to 300 milligram per deciliter. So these are few of the indications in which you have to start the insulin therapy. Now we'll move on to the main topic, that is insulin. How will we give insulin patients? So now we'll talk about the insulin therapy in diabetes. Apart from the indications which I've already mentioned, there is another indication, that is secondary failure of OADs. That means the patient is already taking OADs but HbA1c is still above target and an injectable therapy is now required to lower HbA1c. So if an injectable therapy is required, prefer GLP-1 receptor agonist over insulin. But if despite that the HbA1c is above target, then you have no resort then other than insulin. So when you add insulin to a patient, so first give basal insulin, the dose would be 10 international unit or 0.1 to 0.2 international units per kg per day, and up titrate this dose, up titrate 2 units every 3 days to target, what would be your target? To target fasting plasma glucose, fasting, that means preprandial capillary plasma glucose in the range of 80 to 130 milligram per deciliter. Okay, start with 10 international unit, keep increasing 2 units every 3 days till you achieve this target. Okay, now despite achieving this target, if HbA1c is still high, is still above target, or total dose becomes more than 0.5 international units per kg per day. That means in a 60 kg patient, if the dose of basal insulin becomes more than 30 units, then you have to add the basal insulin. That means bolus insulin or perennial insulin. You have to add the perennial insulin. So at the beginning, you can add this perennial insulin with the largest meal. So what would be its dose? It would be 4 units or 10% of basal dose. Say basal dose is 10 international units, so you will add 1 international unit perennial insulin. Okay, so this is with the largest meal. Now up titrate it again 1 to 2 units every 3 days to keep the post-prandial plasma glucose in the normal range. That means less than 180. But if it is still high, if HbA1c is still high, so what would be the next thing to do? If HbA1c is still high, then proceed to full basal bolus regimen. That means 3 short-acting insulin injections with each of the meal and 1 basal insulin, or mixed-start regimen. Mixed-start, I have told you, pre-mixed insulin. 2 shots are given, 1 before morning and 1 before evening. Okay, so this is about the insulin therapy.